Okay, welcome everyone who's been joining. We're going to start in about a minute. Okay. All right, so I think we're going to go ahead and get started. Um, Welcome again to everyone who's been able to join. Um, I did want to give a couple of reminders. One, you will have noticed that the webinar is being recorded. And two, if you do have questions, then feel free to put them in the chat or the Q&A box, which you would find at the bottom of your Zoom screen. And we will get to addressing those either during the course of the talk or towards the end of the session. So my name is Sheela, and I am excited to be here with our panelists. I am an assistant professor in the Department of Global Health and Obstetrics and Gynecology at the Icahn School of Medicine at Mount Sinai, and I practice clinically at Elmhurst Hospital, which is one of the Health and Hospitals facilities in Queens. And I also direct a partnership which is called the New York City Partnership between the Global Health Institute at Mount Sinai and the Global Health Institute at Health and Hospitals, Elmhurst, as well as Queens Hospital. And through that partnership, we have been aiming to improve the health of communities served in the public system in Queens through building community collaborations that address social determinants of health. And one of my favorite parts of this work has been collaborating very closely with Ancient Song Doula Services and Caribbean Women's Health Association, along with many other stakeholders, including my colleagues at Health and Hospitals and the New York City Department of Health, to build the HOPE Community Doula Program. We've learned so much together about the culture of care in our system and also how to support birthing people in the public system. We've learned how to build a stronger local doula workforce. And through this work, I've met so many amazing people, and I'm very excited today to welcome two of them, Zahirah McNatt and Chanel Porchia-Albert. Thank you both so much for being here. If you will allow me, I'm going to read your brief bios before we start in on the questions. So first, Zahirah, who is a DRPH and HSA, and also the Assistant Commissioner for the Bureau of Brooklyn Neighborhood Health in the Center for Health Equity and Community Wellness at the New York City Department of Health and Mental Hygiene. She oversees and manages the development, implementation, and evaluation of community level and systems level strategies in North and Central Brooklyn that aim to address health inequities. She also leads the Bureau's programming, planning, and recovery work to address racial and other social inequities resulting in premature mortality. Her work focuses on neighborhoods that are disproportionately impacted by COVID-19 due to the histories of systemic and structural inequities driven by racism and oppression. Dr. McNatt's expertise lies at the intersection of global public health, humanitarian systems, and human rights. She has more than 15 years of experience in the Americas, Middle East, East Africa, and Southeast Asia. And her work has spanned academic, nonprofit, and government sectors. She's also championed health service improvements for refugee communities and centered efforts to improve prevention and treatment for non-communicable diseases and mental disorders. Dr. McNatt earned her doctorate from Columbia University School of Public Health and her master's from University of Michigan School of Public Health. So welcome, Zahirah. Thank you for being here. And Chanel Porchia-Albert, CD, CLC, CPD, CHHC. She is the founder of Ancient Song Doula Services, which is a reproductive health organization focused on providing resources and full spectrum doula services to women of color and marginalized communities throughout New York City and Northern New Jersey. Her work with infant and maternal health has led her across the globe to Uganda, where she has served as a maternal health strategist during in rural areas and war-torn areas. Her work in birth and reproductive justice spans research and methods of care of marginalized people and people of color, bringing a human rights framework into birthing rooms, institutional reform, and accountability measures within the healthcare system to address implicit bias and racism. Chanel and Ancient Song's work has been featured on CNN's Champions for Change, the cover of Working Mother magazine, New York Times, Self magazine, and Now This and Vogue magazine, partnering with Baby Dove Black Birth Equity Fund to provide grants for doula services nationwide. And when she's not working on legislative policy or facilitating workshops, you can find her spending time with her family and beautiful 6 children. And actually, Chanel, as she will probably tell you, is dialing in from DC, where she is actively working on some policy and legislative work in our nation's capital. So welcome, Chanel. So happy to have you here. Again, I think this is such an important week. It's Black Maternal Health Week. And this year, the theme is Our Bodies Belong to Us, Restoring Black Autonomy and Joy. And recognition of this annual celebration, our partnership has brought these 2 amazing speakers to you, and really to focus on discussing autonomy and joy in their work to address maternal health inequities and provide support to Black and brown birthing people in New York City. And I think many of you who may be attending today may be familiar with the state of affairs currently in Black maternal health. The United States has the highest maternal mortality rate among quote unquote developed countries. Black women are 3 to 4 times more likely to experience a pregnancy-related death than white women, and 3 out of 5 pregnancy-related deaths are likely preventable. Research has also shown that education and class do not fully account for these inequities. So with that brief background, and there's so much more to say, but I really want to kind of learn mostly from the experience of our 2 speakers today. So Zahirah, I wanted to start with you. And I know that you have been focused on addressing health disparities. Can you share a bit about your work, specifically around maternal health within your Bureau of Brooklyn Neighborhood Health?
Sure. Well, thank you all so much for the opportunity to engage with you, Sheela, and with you, Chanel, and with the audience that's here. It's a real pleasure to be able to connect. And I might maybe extend your introduction on data a little bit with a few more points, because I think the data for the nation is problematic, and then the data for New York is even more problematic, right? And so when we think about in New York City, Black women being 9.4 times more likely to die as a result of their pregnancy experience. And we also talk about prevention. And so we have said that 75% of Black women's deaths essentially are preventable. And that's compared to about 43% for white women. And what that data tells me is that we know how to save white women and birthing persons' lives. And for some reason, we don't know how to save Black birthing person and Black women's lives, right? And so I put knowledge in quotations because obviously we know how to save lives in relationship to birthing, and that we are executing that differently for white women and birthing persons and versus Black women and Black birthing persons. And so I always like to center the conversation around the data being particularly problematic in New York City, and then what we know about what to do being on the table for us in many ways. You asked the question about sort of what are we doing in the New York City Department of Health and Mental Hygiene. I've been in the DOHMH for 15 months. It is a wide-reaching institution in many ways, and so there are lots of different types of work. The first, I think, is very policy-oriented, and so really excited to hear about Chanel's work in DC now. But a lot of that is tied to everything from breastfeeding-friendly designations so that neighborhoods and businesses and communities allow for safe and comfortable breastfeeding, to thoughts about value-based purchasing for hospitals in relationship to maternal health outcomes, to appropriate Medicaid reimbursement for doulas, as well as other kinds of comprehensive integration of health and social services. all the way to parental leave and maternal leave, and how we allow for and create better opportunities for particularly Black and Brown women in New York City to be able to claim that time for themselves and their families. So there's a lot of that sort of policy work happening. There's also a lot of service delivery work. And so I know folks are familiar with some programs more than others, but there's the New Family Home Visits program, which is all about bringing folks to the homes of birthing persons and supporting them during the pregnancy journey and postpartum. We also have the Citywide Doula Initiative, which just launched last year, and was sort of based on all of the amazing doula-related work that's been happening in New York City and in Brooklyn specifically for decades, and by organizations like Ancient Song and Caribbean Women's Health Association and Brooklyn Perinatal Network and Mama Glow and so many other CBOs that have modeled what the work should look like so that government can support and invest in it. And so there's just a lot of this sort of service delivery work. And then I would say there's this component about hospital relationships. And so how do we work better with hospitals and supporting their quality improvement? And how do we think about accountability when we are underperforming in the hospital setting or really any other setting that birthing persons are making their way? And then I think maybe the last category I would mention is just around education for individual women and birthing persons. And it's been really exciting in Brooklyn to be joining the Brooklyn Borough President through the Borough President's Maternal Health Task Force and executing a maternal health education campaign for women and birthing persons in the borough. And so there are lots of different ways we engage and continue to learn along the way so that we know how to engage better over time. But those are some of the components that come to mind.
Thanks, Zahirah. Yeah, it's I know it's a big task, and there are a lot of different components to work. So I appreciate you outlining all of that. And Chanel, I would love for you to also share more about your work and how I know that doula work has kind of a unique role in addressing some of the mechanisms of the disparities that we've been talking about.
Yeah, so Ancient Song has been in this space since about 2008, working and serving all of the boroughs in New York City. And our work is primarily focused on, and it really comes from a birth and reproductive justice perspective of really wanting to center, Black women and birthing people throughout their reproductive life course, right? And so understanding that, pregnancy is one episode of care, but also what happens during the continuum prior to and afterwards. And so, I've trained and certified doulas to do this work and to be able to provide services. Currently, right now, we are part of the New York City Wide Doula Initiative. We've also been a part of previous iterations like Healthy Women, Healthy Futures. That was around a couple of years ago. And working with, hospital-based institutions and providers to really provide education to make systemic change, right? And so understanding that, arming or preparing the people that we're working with information is just not enough, that we need systems level changes in order to make things happen. And I think that's also where the policy comes in. And so within New York City and New York State, we've worked on and continue to work on informed consent laws and substance usage when it comes to pregnancy testing, especially for those who are low-income Medicaid recipients. We've been working on Medicaid doula reimbursement and the impact that it could potentially have. And so, if you're not up to date, currently right now, the fiscal budget for 24 has been delayed multiple times. And, we're really working to advocate to ensure that doula reimbursement at a rate of $19.30 gets added into the Medicaid, gets added into the budget, as well as a $10 million allocation. And then on a national level and international level, we also do work. And so last year, traveled to Geneva, Switzerland, to the United Nations to provide testimony on racism and maternal health and its impact, on a community level, but also within the institutions of healthcare. And then here in DC, working on the Omnibus Act and the 12 bills that are included within that. This morning was with Lauren Underwood, Congresswoman Lauren Underwood, and others, as I'm a part of the Black Maternal Health Federal Policy Collective. And that is, reproductive policy experts, in particular in the space of maternal health, who have come around from the nation to really bring attention to maternal health issues. And so, a lot of work is happening. And then, of course, the Hope Doula program, which is something that I have been working on for 10 years in the making. I just have to make sure that we put that at the top of the list. But really happy to see it actually come to fruition. And yes, it's not without its little hiccups that can oftentimes happen. But I think that what's really great about it is that it's really been really intentional about centering community, about centering providers and how they're able to provide care, and meeting people where they are, not where we expect them to be. And I think that's a two-way street, right? It's not just, putting all this pressure on the provider, but also understanding that the systemic barriers that they come across when trying to provide services. And so much to your comments, Zahirah, just in terms of knowing how to take care of white patients, but what happens when it comes to taking care of Black, Brown, and Indigenous people. And so really wanting to center that conversation and bring, elevation to it so that this disparity so we can stop talking about it, stop saying it's a disparity. And uplift the joy that comes with bringing a child into the world.
That's actually a perfect segue, Chanel. I think I did want to kind of turn towards that, that topic of joy and autonomy, which is really the focus of Black Maternal Health Week this year. And I want to start with just the basics and how you both think about those words, autonomy and joy, and what they mean to you in your work. And do you want to? Yeah.
Oh, I guess. So I would just say, in terms of my work, centering autonomy and joy is really someone knowing that they have bodily autonomy and what it means for them to center themselves and affirm themselves within their reproductive health choices. And that looks different for different people, right? And understanding that, right? So it's really asking them a simple question. It's what does support look like for you? And really starting out from that touch point, not, what's your health history? Tell me, what brought you here today, right? But really from a place of, how do you define support? How do you define care? How do you envision your birthing experience? And if you've never even thought about it before, let's talk about the options and the ideas that you have around what can happen. So, for me, being able to center that autonomy is really focused on human rights and bringing that into the birth room, where someone, again, can feel seen, they can feel heard. And then that joy then becomes automatic, right? It's the understanding that it's not just about having a healthy, child and a healthy parent, but it's also about, how did I feel within that experience? Did I feel like people were listening to me? Did I feel like I had options, in that particular moment? Did I feel like I was able to make an informed decision about my care? Was I did informed consent happen on a continual basis? Or was it just something that, because I signed myself in, that's what, that's the only touch point that it happened? And so it's really about, and someone not having to say to me, do I need to get a medical proxy in order to have a baby, right? And I think that that's important, because the narrative that has been told, and while I understand it, has been Black women and birthing people are in crisis. Black women and birthing people are dying. But we're also not looking at the ways in which we carry messaging and how that also can become an allostatic load that someone starts to carry that is compounded with racism and implicit bias. And then, you have the social determinants of health, of having maybe inadequate housing or the other things that can happen. So really wanting to center them in a framework of, yes, the acknowledgement of those things are going on, but that's not the only thing that matters, right? The acknowledgement that you matter, and that you are seen, and that, you're a part of a whole community, and that whole community sees you and understands that, without you, then there is no community, right? And so for every maternal death that there happens, I think we also have to look at it as a loss in community, and like how the degradation of a whole community happens when you lose a parent, and I don't think that we oftentimes, frame it in that way. And I think it needs to be, in order to really say, woo, well, if that's the case, then how am I centering this person's humanity in the best possible way? And in knowing that I'm centering that person's humanity, then I'm also centering my own too, because we're not separate of, but a part of. And so, that's how I see centering autonomy and joy within this work and the people that we work with every day.
Thanks, Chanel. Yeah, go ahead, Zahirah. Thank you.
Excellent. So I echo all of what Chanel shared. I mean, I think that, when I think about joy, I think about the way our families approach birth, right? And often that it's this intergenerational opportunity to celebrate life, to take good care of a woman or a birthing person, and hold that person close as we move through these experiences, and that we think generations out about how we care for the societies that we're in. And so I often think about birth and a desire to bring life forward as a real commitment and belief that the future is going to be bright, right? Whether it's next generation or 7 generations out. And so I often think about joy in that regard, as to how do our families and our communities feel when we know that someone new is coming to the space. And that we are, because of what we do in this work, and because we are shining a light on inequities, we are automatically starting with the problem in our language often. And so I think that we have the opportunity, and I love the theme for this year's Black Maternal Health Week, because we have the opportunity to shift that language. And make sure that mothers and birthing persons know that safety and their safekeeping is the center of why we're even in any of these conversations. And so I think there's just so many reasons for us to be joyous around the work and around being a pregnant person at this point in time. When I think about autonomy, I think about our sort of our human rights, our know your rights work. And so there's a lot of work, whether it's DOHMH or CBOs or other organizations, about helping folks know what their rights are and being able to feel comfortable exerting those rights in the experience of pregnancy, labor, and birth, and also in the postpartum period, and quite frankly, in all the other aspects of your life. And so I think about autonomy being about the birthing experience, but also about our ability to activate our activism, our community organizing and community mobilizing, like building those strengths within ourselves and our neighborhoods, because it's our autonomy in every place and space that then allows us to come to this one experience in our lives, which is pregnancy and birth, and be autonomous there too. And so those are the things that come to mind when I think about joy and autonomy, and really grateful that the Black Maternal Health Week theme allows us to kind of flip the conversation on its head.
Yeah, thank you. Those are both really kind of inspiring, I think, points and important ones. And I think you started to address this a little bit already, Chanel, but just coming back to kind of specifically how you might foster autonomy and joy in birthing people as you do your work. And again, I think you started to bring this up through the reproductive justice framework, which I know all of your doulas are trained in, and a human rights framework. But I don't know if there were some other things that you wanted to bring. I know in your presence, I've laughed a lot. So I think there may be some other pieces there that you might want to bring.
Yes, I definitely think it's important to laugh. I mean, to create moments of peace. There's so much going on in the world that I don't think that, and we're always in the process of doing, like, I have to do this. I'm looking towards that. I'm moving towards something that we don't actually give ourselves the opportunity to like just be in the present and acknowledge like where we are. And so a lot of, the work that I do with whether it's with, the community members that come in to be served, or doula trainees or providers, is to like go through mantras of like, I see you, or for them to say, I am here, I am present. because I think oftentimes when you're doing something and you're in the act of service, which we all are, right? We're in the act of service to others. We forget to fill up our own cup. We forget that we too are experiencing things. I also like to look at it from the provider perspective, because I think oftentimes in the conversation, the narrative can be pointing a finger at providers, and not necessarily working with providers to understand the nature of how internalized trauma can also cause someone to then make that trauma that they have experienced that has gone unchecked, right? They haven't had an opportunity to express now becomes normalized behavior, and that is perpetuated on patients on a continual basis, right? Without even realizing that you're doing it. And I think that's because a lot of the relationships that we happen to have in healthcare happen to oftentimes be transactional. So then what does it mean to then center an intentional focus on understanding that, again, we're all humans having a human experience in it. So then that means we need to laugh. We need to have good food. We need to talk about the ways in which we're engaging with each other. We need to challenge each other to be better, right? And to consistently lift up frameworks of care, right? Of self-care, of joy, of mindfulness, of moments of reflection. So it doesn't necessarily have to feel like it becomes a combative relationship of it's us against them. And understand that it's not. It's a system that wasn't necessarily, that's not created to serve anyone in an equitable way, because it also doesn't center providers in a way that allows them to do their work from a space that's not filled with burnout, and mental health, stressors and other things. And so, yeah, I'm really intentional about making sure that comes to the forefront, because I think oftentimes that is left out. And I'm sure there's many more, but my brain is like, do.
That's great. And I really appreciate you kind of bringing the workforce into this conversation as well. I think that's another important kind of layer here in terms of addressing disparities, really getting at kind of the source of some of the traumas that are perpetuated, or the way in which burnout can then lead to a change in quality of care, or a change in the communication or trust in the relationship between a provider and a patient. So yeah, Zahirah, did you want to add also to how the DOH would be participating in fostering joy and autonomy?
Sure. Thank you for that. And I appreciate the centering on the health workforce as well. I think this is a place and space where DOHMH is learning a great deal from other environments about how to do this well. What I will share from the workforce piece is that, particularly in maternal health and birth equity work, we have recognized, I think, what Chanel mentioned around sort of the burnout. And so, the light touch work that we've been able to do is really about how do we create spaces for grounding, and how do we create healing circles, and how do we do this sort of work that allows the folks who are supporting communities but often don't have an outlet for whatever is happening that weighs down on us and makes it hard to be joyous. And so we've actually just this year and late last year begun to do some of these healing circles that have been for our own teams, but then also for birth workers in the city. And that has been, I think, eye-opening to just see what people need out of spaces and environments like that. But then I also wanted to share sort of the joyous piece of being a pregnant person, and how do we support that joy, right? And we have these environments, and there are 3 very small ones across the city, but one in Brownsville, Brooklyn, one in East Harlem, and then one in the South Bronx, and they're called Family Wellness Suites. And they are essentially these very beautiful, colorful, playful, vibrant environments for people who are pregnant or postpartum and their families. And just last week, we had one of the events in in that space and had just about 100 families showing up over the course of the day. And all sorts of things happen there. It's the New York Public Library does their read-alongs in our space. We have breastfeeding support groups and other kinds of support groups. Doulas show up in those spaces to talk to pregnant women and help them understand if they want a doula, what that experience might be like. There's lots of stress reduction. So there's prenatal fitness and mommy and me yoga and, clothing giveaways and all those sorts of things that I think are often, because we're so worried about our concerns around morbidity and mortality, that sometimes we lose the pieces that are about I want to say embracing the pregnant person and their family through the journey and the joy of it all, and the joy of being in the same space. Many pregnant people together makes everyone smile, right? And being able to tell stories and think of names and just the power of what our cultures bring to that space. And so I wanted to uplift these 3 locations, which don't get lots of shine generally, and the staff that are there are lactation counselors and social workers and many others. And so in these family wellness suites, it's a place for folks to self-refer into and or be referred by clinicians and others. And they are, warm embraces, I would say, to pregnant people and their families, and allow for the kind of joy that we're talking about in many ways.
That's wonderful. Thanks for sharing that, Zahirah. And I was able to paint a picture in my head of being in those spaces. And I'm putting in a plug for the one in Queens to open sometime in the near future.
Me too.
That's great. And actually, we do, just to kind of go back to the workforce question, we do have a question in the chat that I think we can answer now before going on to the next question. So what measures, this is Ebony Brewster, what measures, if any, are currently in place to draw more Black doctors to our healthcare organizations in New York City? I work for Mount Sinai, and I can say our representation is severely lacking. And maybe if you could also comment on that idea of having doctors of color treating patients of color as well. Whoever would like to take that.
So I am not a physician, but I will say that in working with physicians, I think it's really important to support them. We understand that Black physicians in particular face a lot more barriers in terms of economic stability with school, student loans, things of that nature, really being able to serve in the communities that are going to sustain them, but also affirm them, not just as providers to their community, but within the actual institution. And there has been a lot of institutional barriers to physicians of color being able to come on or even wanting to stay on, right? Because it's not that they don't become separate from the implicit bias or institutional racism. They too are affected by that. And I think that that's why it's really important to, when wanting to build up the perinatal workforce as a whole, really putting certain things in place to ensure their safety and sustainability within the profession. Right. And so it's not just about inserting providers of color, right? Because you don't want to put them in a harmful situation where then they too find themselves not being able to provide services in a way that they may have wanted to. And so I think it's a twofold, I think that the workforce needs to be lifted up. It needs to be, we do need more providers from various different backgrounds, in particular providers of color. But I also think that they need to, and there needs to be some sense of security that's put in place to ensure that when they do come within those institutions, that they too are safe and they have the necessary supports in place. And so if you're working in a high needs area, such as and this is not to say, much like teachers, then you go into that area, you should be able to have your loans forgiven, right? Or partially forgiven if you're working directly with the communities that you want to serve. Allow for some incentives for those providers to want to stay, but if they are in hostile environments, or environments where they're not able to allow for their creativity to address the systemic needs of the communities that they're actually practicing in, then you're going to find providers that come in with the best of intentions, but then who also leave to either go to more lucrative positions or open up a private practice because they don't want to have to deal with the policy and the restrictions and the inhumane treatment that they face when they're in those positions.
That was impressive for a non-physician, Chanel. I am on board with all of what you said. Zahirah?
In total agreement. I'm like, and we're done. I feel like that's it. Because, what is concerning in many ways is that now when we start to look at the data, racial congruence is resulting in lives saved, right? And so when we're seeing that your clinician is Black and your client is Black, that we're starting to see study by study that more Black people survive in those circumstances than when their clinician is white. And that is challenging and problematic in many ways. And where we're seeing this most right now, or the most recent data and research, is around infant mortality, right? That we're seeing, if your clinician is Black, in that encounter, that you have more likelihood of survival for your infant. That says so much about the state of America, right? It's not even the state of the institution that you're in, or the one person who we might want to target in some way, as Chanel is telling us that we shouldn't, right? That these systems and structures are unwell, as is the nation in many ways. And so I say that just to say, so we know that racial congruence is saving lives. We have to deal with why that is and how do we adjust for that, because it shouldn't be harmful to show up for any kind of clinical experience and see someone who doesn't match your race and then know that that could be a harmful encounter. I do not do physician recruitment in any way in DOHMH, but I would echo everything Chanel shared. I mean, we hear from residents all the time who are, in their residency experience, being abused, being challenged in ways that are not appropriate, being challenged in ways that are not similar to their non-Black or non-Latino colleagues. We're just seeing a lot of harm being done to medical students, to residents, and then to people in their early career as clinicians in these kind of work environments. And so if we're hoping to hold on to Black and brown clinicians, we've got to figure out the racism inside the institution. And it makes sense, because if we're trying to be anti-racist in our care for clients and community, you've got to be anti-racist in the four walls of the institution that you're in. And what we understand is implicit bias has been the answer and the checkbox across the nation for a long time, and it is not an effective solution for structural racism. And so it might be a beginning, it might be a nice conversation, but if our institutions are just doing implicit bias training, we are failing. And so there's so much more work to do to care for Black and brown clinicians in order to hold them in the environment, in order for them to then serve the public well. And at the same time, there's so much more to be done around the accountability for non-Black and non-brown clinicians so that they can serve the public just as well. And I think that we have to be able to do both of those things in the institutions that we're all a part of.
Thank you for that, Zahirah. And this is actually a good transition. I wanted to take a minute to ask you both to kind of take a step back and look at the healthcare system as a whole, and share with us your dreams. So if you could, kind of redesign health systems to really center on autonomy and joy for birthing people and those who provide care for birthing people, what would it look like? What are some of your biggest kind of asks? Who wants to take that?
I guess I can go. Well, one, I think, when you're working with individuals who are in a space, right, and they're caring for people on for long periods of time, right? And so if you're working a 12-hour shift or more, you need a space that's welcoming, right? And so, you know, I train medical residents and mentor them as well. And I think what I've found is like, I've seen them in places where I'm like, this is not conducive for anyone's mental health and being able to center you. And so one, I would redesign what the labor and delivery floor looks like, and really design it so that its functionality is centered around, yes, providing adequate care, but also, you know, what would it mean to have like a birth tub in every room? What would it mean for folks to have accessibility to other options besides, you know, in terms of pain management, besides just the epidural? So like having a birth ball, having like different instruments that are used at, you know, in other spaces. If you travel to other countries, especially within the United Kingdom, you can go into a birth room and find various different modalities for a birthing person to use within their reproductive course, life course, or in their labor and delivery. You know, have a nice lounge area where providers can go and find respite. You know, have a family area where, you know, they can walk, even it's like a walk around, or, you know, not just a TV in a room with hard chairs. Like, that's not welcoming and friendly to anybody. Add some plants into the space so we can get some oxygen. You know, and it sounds like something that, you know, it's things that are so simple that, you know, provide a blender so somebody can make a smoothie, you know what I mean? Like throughout the course of their day, because you find providers who end up eating poorly, right? And you're in healthcare. And so because of the fact that you're always on the go. So like, what does it mean to like just do small things and, you know, in order to create some sort of joy? When you have a happy workforce, then you can have people who are also provide happy and culturally congruent care. I saw someone ask a question in the chat that, you know, that was centered around how do we have Black physicians that are culturally competent? And I think that, you know, it's not about having cultural competency, right? Because that's still a checkbox. But what does it mean to come into a framework and be humble? You know, what does it mean to center a cultural humility framework where we're learning from each other, where we're understanding that it's not transactional? Because yes, you too can bring someone of color into a space and they still can cause harm if they're being taught within and from others who are perpetuating that harm, right? And so again, this is how harm becomes normalized behavior that then becomes perpetuated over and over again. And so I think it's really about the intentionality of the individual who is providing the care, to really say and make a conscious decision that they want to change something, and they want to, you know, and I think that starts with just like reading. You know, there's so many books to read. There's Medical Apartheid. There's, you know, Killing the Black Body by Dorothy Roberts. There's, you know, even a simple book like All About Love by Bell Hooks. You know, and she also has this book called Teaching Community, a Pedagogy of Hope, right? And it really talks about community-based frameworks. Like, what does it mean to be in a community of a community and be a service of your community in every single way, right? And so I think a lot of it starts with the individual, and then that willingness to want something more and to want to do something different, but also that fervor that takes to go against the grain of what you see every day. And again, it doesn't mean that you have to be radical about it and, you know, put up a sign and all of those things. You could do something as simple as like, you know, bring a plant, you know, bring a blender, you know, to a space, like change the framework, the culture of the space, right? Which then can change the culture of the ways in which people change. Because that's essentially what we're asking people to do. We're asking them to change a culture of care that's been around before even I got here, before I was birthed into this world. And that's hard. That's hard because people become conditioned within, you know, within certain environments. And so it's about unlearning learned behaviors and really wanting to challenge ourselves to create spaces that are better for all, for every person, for every birthing person, for every pregnant woman. So that's how I would redesign it. I think, you know, I don't think that it's anything that's really far off. But I think that it's something that's really needed just to, in order to center the mental health and well-being of everyone who walks through the doors, and gets care and provides care.
Thanks, Janelle. I like that attention to detail. I think we're currently undergoing a redesign at Elmhurst for our labor and delivery. I'm going to have to get you in the room to help us brainstorm.
That's wonderful. I was thinking the same thing because I think soon enough, Coney Island, Kings County, and Woodhull will be going through these experiences too. So I'm like, oh, they should get you on whatever is the advisory council to think about space and healing and culture change. So thank you for that description. I think when you asked the question, Sheila, I immediately went to sort of large systems change. I mean, I find it, a lot of my work has been outside the United States, and I find it really difficult every time I come back and spend time and work within the US environment, that universal health coverage is such a far distant conversation, and that is seen as though it is just impossible in this environment, in recognition that so many other countries similar to us in all the ways that we think similarity are important, have been able to achieve that. And so when I think about healthcare services in the United States, and then particularly for pregnant persons, I think about what would universal health coverage look like, and what would its impact look like. And not because, we were like, oh, we get Medicaid to cover you for 1 year. It's sort of like, what? Like, I've needed Medicaid my entire life, or I've needed health insurance my entire life, and then I get coverage for this moment, and then I lose coverage again. And so there's so much momentum globally around universal health coverage, and you sort of see it in the US at this very light touch, and there's just so much opportunity for us to be on the global bandwagon and to make those demands within this national structure. I also think about guaranteed income for pregnant persons, right? And the fact that we're sort of scrambling to say, we've got to get housing right for you because you're pregnant. We've got to protect you from intimate partner violence. We've got to keep ACS out of your house. And we've got to make sure you have access to fresh fruits and vegetables, and that you don't live in a food desert. And we've got to get you into the healthcare part of the experience that is supposed to be in existence for you and supportive. And so we're calling upon all these things that we want people to be able to have. And really, if we just had guaranteed income, people would have money in their pockets to make the kinds of decisions they would need to make in relationship to both social and health services. And so I think there's a lot to be said in that domain. And these are often, both universal health coverage and guaranteed income are things that we think in the United States are socialist, right? But we're willing to be socialist in many other places and spaces in relationship to what we do in US policy. But then when it is for Black and Brown lives, and for those who have been historically living in disinvested neighborhoods, we can't find the policy strings for that. And then the last thing I would say is that, this may not feel joyous, but I think institutional accountability for structural racism will bring about joy later, right? And so I would love to see us be able to practice what accountability looks like. And Doctors Michelle Morris and Bram Wispelway, wrote about the healing arc model, which really talks about acknowledgement and redress and closure when we are discussing harm and structural oppression and structural racism in health and healthcare. And I'd love to see us start practicing those kinds of models, because it might be tough in the beginning, but when we get to the end of truth and reconciliation and justice and healing, joy comes with that. And so, but we've got to tell the truth somewhere in the midst of those processes. And we're not really good at doing that at the intersections of public health and healthcare in New York and across the country. And so those are the things that come to mind when I think about what a glorious future in this space could look like.
Thanks, Zahirah. Yeah, those are such important issues that just don't get enough attention and enough discussion in the American healthcare context. I really appreciate you bringing that global perspective as well. I think we're going to send a reading list out to this group, because we have so many interesting and inspiring and informational things that have been coming up in the conversation, from articles to books to poetry. So I might ask you guys to do that afterwards. So I did want to, leave, we're kind of at 10 minutes from our end time, and I did want to give the opportunity for folks to put in any additional questions or either in the chat or in the Q&A, and we can try to answer those live for you. And while people are doing that, oh, sorry, we have the first one, and then I'll add one in the mix as well. So the first one here is, what else can be done to bring more awareness of Black maternal and infant mortality?
I would just say keep having the conversation. I mean, when I first got into this work, the only spaces that I had really heard about infant and maternal mortality and morbidity was around Black midwives. And they were the ones who were really like pushing the conversation. And it wasn't until around 2017 where, you know, the Black Maternal Health Caucus was formed, and, you know, the Momnibus Act is released in 2018, and we really started to push that conversation, and Black Mamas Matter Alliance is formed. Then you start to hear the more on a national scale about Black maternal health, but prior to wasn't even a conversation. And so I think it just is about continuing the conversation, about sharing information and knowledge. I don't think that it necessarily needs to be shared in a scary way. I think it could be shared in just a conversation around preparation sometimes, and around the conversations that happen prior to someone actually becoming pregnant. I think the other, you know, one of the biggest issues in the United States is that we make pregnancy seem like it's like this mythical creature. And so, or there's a lot of conversation around like, don't get pregnant, don't get pregnant, don't get pregnant, but never a conversation around, well, what happens when you become pregnant? And this is not just for teenagers, this is for like adults. You know, I see, you know, adults who are in their late 20s, 30s, 40s, who have no idea about what their reproductive health options are, you know, about their bodies, about how to trust their bodies. And so I would say, you know, start with a conversation, with simple conversations around like, what does it mean to listen to your body? What does it mean to have conversations around reproductive health as a whole, you know, cycles and menopause and, you know, everything in between. You know, that's not something that we openly discuss about miscarriage and stillbirth and abortion and, you know, what it means to have a baby, but also raise a child. And I think that's where the real reproductive justice and birth justice framework comes in at, because it's touching on all of that, right? It's talking about the primacy of self-care. It's talking about when someone wants to have a child, not have a child. It's talking about, you know, raising those children in safe communities, right? And that all is centered in conversation, you know? And so, you know, if you want to make a little handout, make a handout. If you want to be that one friend that's like, child, did you speak to the person I told you to speak to, and then follow up, like anything, it like all of the little things, like while you at dinner or going to get your nails done with somebody, like bring it up. And yes, you'll be the person who's always, oh my goodness, you're always talking about that. I sure am. I bet you'll come to me later. And it makes a difference, because when we think people aren't listening, like they hear us. And even if they can only get the little sound bites, especially nowadays, it's like, shoot, put it to a song, like create a song, make a rap, like make a TikTok, like do what you got to do to bring the message out. And I think it's really truly though about meeting people where they are, not where you expect them to be. So that means that you need to go to where the people are. You know what I mean? Like we can't be afraid to go to the nail salon, go to the club, like pass out flyers at the block party during the summertime. And, you know, in New York, it's full of block parties. I never see anybody out there that's really talking about Black maternal health or healthcare in general, you know, and I'm not just talking about like a regular healthcare booth, like get a street team, gather some folks, like, you know, host a cookout, anything to bring awareness and education. And it's like, you know, someone just said, like planting seeds. It only takes a 2 seconds to have a conversation with someone. If you make eye contact, say, hi, what's the vibe? And you can just give your whole spiel.
Thanks, Chanel. I'm looking forward to this summer and being on your street team. Zahirah, did you want to add to that issue of kind of awareness raising? And someone added here too about community health centers and churches, which maybe does have some intersection with the work at DOHMH. I don't know.
Sure. Thank you for that. And thanks for the ideas. I will host the cookout and the street team. So, I think I echo all of what has been shared. And I think the only thing I would add is that maternal health is a concern across the globe, right? And so the opportunity to build the kind of international and global collaborations that help to do things like center midwives, center doulas, center community health workers, right, as the cadres that actually move the marker. Like, we've already seen maternal health improve in countries across the globe, and it is like, we have to be humbled. It is not people with doctorates of any kind that are moving the marker on maternal mortality and morbidity, whether it's in a low-income country or a high-income country. And so there are these roles that we are finding and learning are really important, that are community roles that are significant. And so being able to uplift those roles, I think, are key, and being able to build the kind of international global collaborations. And an example of that is that we have, some amazing colleagues in Brazil that are doing this kind of work. We have amazing colleagues in East Africa that are doing this kind of work. And being able to say that this is a movement that is not just about birth, it's actually about the value that we place on women across the globe, right? And so if we were valuing women in more positive manners, we would be able to have and place value in their birthing experiences. And so the only thing I would add to what else can we uplift is to build those relationships across all the boundaries and barriers and walls and fences that we have built in our professions, and that we have built between nations. And I think that many movements require movements across all of those boundaries and barriers, and I think this is one of them.
Thank you for that. One last question around mental health. Mental health is something that, is a contributing factor in a lot of that preventable maternal mortality that we spoke about earlier. And postpartum depression affects about 10% of women after birth. And treatment is actually out there and often very successful, although there is some data to show that Black women receive treatment at a much lower rate than white women. And so I was curious about your thoughts on postpartum depression and mental health in your work. Whoever, wants to take that.
So maybe I'll jump in. So, thank you for this question, because I think that this is an area that just doesn't get enough attention and or funding or investment. And as you've said, treatment is effective. And so I feel like it's often sometimes just simply important to say that treatment is effective. And so coming forward as a pregnant person to say that you're having challenges with mental health or behavioral health can be really important. I think, the things, we're probably getting a couple of things right within DOHMH, and then a bunch of things we are getting wrong or we haven't even touched yet. And so screening and referral is something that all the programs that we do that are maternal health or birth equity oriented are currently doing, right? So screening for perinatal mood and anxiety disorders and referring to clinicians of all different kinds all across the city. What that has taught us, though, is that there aren't enough clinicians across the city who can actually treat pregnant persons with perinatal mood and anxiety disorders. They might be generally able to work on depression and anxiety in the general population, but not having the skill set for this particular population. And so there's this need for getting more providers, just the numbers, more providers of color, and then more providers of color who have specialized training in perinatal mood and anxiety disorders. I think we're also recognizing the stigma. So we know there's stigma attached to mental health and behavioral health and substance use disorder challenges. We've known that for a long time. But the stigma for pregnant people, right, is 100 times fold or 100-fold in many ways. And the stigma is not just the feeling, it is what the system does to you when you step forward and say, I have depression or anxiety, or I'm experiencing psychosis perhaps, or I have an opioid addiction or anything else. And what we are really understanding is that when mothers finally tell us that that's a concern, then they won't speak up, because the fear is, particularly in Black and Brown families, that ACS will step in, right, tear apart your family as a result of you saying you are vulnerable and you have a concern. And so I would love to see the championship that that sort of didn't exist for the crack cocaine era in the 1970s and 80s, that now exists for this opioid era, to then be that kind of grace and empathy to then be applied to pregnant persons who have these concerns, so that we figure out a pathway that is not we tear apart your families because you've said you had a problem or we identified a problem, but instead that we figure out how to hold your family together and then support you in becoming well. And we haven't done that, right? And so asking women to come forward and say, I have a mental health concern or I have a substance use disorder right now in New York is asking them to risk their family, particularly if they're Black and Brown. And so I think we have to deal with stigma and with the system's response to raising the flag that we are in need of care. And then the last thing I would say is that perinatal mood and anxiety disorders actually exist at a higher rate in Black and Brown populations who are pregnant. And we know that that's because of the experience of racism and the experience of structural racism and the social determinants of health that we talk about in all these other domains. And so if we're worried about the outcome of potentially having a perinatal mood and anxiety disorder, we've got to go way back to where we should be working on many other things around housing and intimate partner violence and food access and so we never get away from these structural determinants of health, but we also never put our money in those places and spaces. We are investing in healthcare systems, but speaking to structural determinants of health, but not putting our money where our mouth is. And so those are sort of the directions I would love to see us go in relationship to perinatal mood and anxiety disorders, particularly in the Black and Brown community in New York City.
Thanks, Zahirah. That was super comprehensive. And I really appreciate the levels of structural and provider and then stigma kind of even on the community and individual level. Really important and big challenges. Thank you both for this conversation. Really, really appreciate it. You guys both are doing amazing work. And I think I feel privileged to know both of you and to hear more about your thoughts on autonomy and joy in Black maternal health tonight. So thank you again. We will be sharing some resources and things with everyone who's registered for this event afterwards. So if there's anything else that you guys would like to share with our group, please do also send that along and we can share that through the email that goes out to everyone registered as well. Someone also just mentioned that the recording of today's event will also be posted. So thank you so much again. Really, really appreciate you being here. Thank you.